welcome everybody here at this Philips Symposium with a few interesting talks. As you know, Philips is everywhere, and we are going to talk about the pre-stroke phase. Mark is going to talk about some new tools that we can use. We talk about the Angio Suite. I think Nicole will talk about more about the Angio Suite, and also the follow-up of patient or the secondary prevention. Manish will talk about that. So there are some interesting talks, I think. We decided to have the talks first and then do the Q&A afterwards. So we ask you to remember your questions or write them down or whatever, depending on your age. You have to write them down or just remember them, I think. And then you can ask the questions afterwards. That makes it, I think, a bit more fast. And one of the things we talk about is the speed of treating stroke patients. So first speaker here is Mark Ribot from Barcelona, and you probably know him. He's involved in many, many studies, always traveling around. Now, fortunately, he can be here and talk about one of his topics that he has. Mark, the floor is yours.
Thanks, Wim, and thanks, Philips, and the audience for being here. So you asked me to present this technology. This is a startup company that is located in Israel, and my relation with them is that we collaborate in the development of the technology that I'm going to show you. We collect patients for them, and we help them, with this data to generate the nice algorithms that I'm gonna show. So as an introduction, many years ago, this is from 1960. So 63 years ago, somebody drew this cartoon, imagining how the medicine of the future is going to be, and basically the patient would get into one of these booths and connected to these machines and computers and an algorithm. But they focus that the algorithm will be checked by physician. So this is, I agree with this. But finally, the machine would prescribe some kind of treatment and make the diagnosis. We are probably heading to somewhere like this. This is also something I like to do when I have to speak about a topic, to check what is the impact on publications on artificial intelligence, and then here more focused on stroke. There's an exponential growth of the publications. Probably we're somewhere like this in a hype cycle, right? I don't know exactly where we are at, but I'm sure it's going to grow a lot. And this slide shows the devices with AI approved by the FDA over the years. So the first one was a very long time ago, and like an exception, and it was related to cytologic studies. But again, you see, there's an exponential growth of approved device by the FDA, and basically the vast majority is related to radiology and imaging. And if you look at, according to organs, so head is still the number one. So we are in a field that is prone to this kind of devices, developments, and we are all very used to the algorithms that analyze imaging. But there's much more than analyzing imaging with algorithms. So how can we help these guys in the field when there's a stroke? So this technology, basically what it does is you have a module that the person that is with the patient will acquire some files, video files, with any cell phone. These files will be uploaded to the cloud, and the algorithms will do its job and will send back the analyzed information to the team. So this is how we do the acquisition in our ER department. This is one of our collaborators, And basically, you can acquire. You do your neuro exam. It takes 2-3 minutes, or even less, and and this is on the left is what can be seen on the receiver's handheld or cell phone. So this patient is having an acute stroke, and then I will go through the technology now. But this is very easy. So in 2-3 minutes, the person that is with the patient makes a quick video, follows the instructions that appear on the screen of our cell phone, and this allows to do an asynchronous evaluation. So for those of you who had done telemedicine for acute stroke, systematically you start your evaluations with, can you hear me, can you see me, focus there, focus here, I cannot hear you. So this, you can get rid of this because the algorithm just shows you what you really want to show. And for each item of the neuro exam, you can have the most important images that are automatically selected. So you can go through the maximal face palsy image to the maximum drift of the arm, and you go one by one. If you want, you can manually do your NIH stroke scale, but this allows easy neuro evaluation in a very short time, but getting rid of what I just told you. So here, for example, you see the algorithm picks the frames in which there's the maximum asymmetry, and it shows them to you. Then the algorithm is able to make a prediction of diagnosis, if this patient has having a stroke or not. And if it predicts that the patient has a stroke, it can also predict if the patient has an LVO stroke or not, like here. So in order to better explain this technology, I'm going to show you how it works. And you can also see this. So let's go through a patient that was admitted with an acute stroke here on the left, and on the right, it's 3 days later. You see most of the facial palsy has improved. So this is what the algorithm can show you also. It can measure and quantify the degree of asymmetry. It detects several points on the face of the patient and tracks the movement, and you can see how there is an asymmetry between left and right, and this asymmetry that was quantified to 85% dramatically improved. Here. Dramatically improved 3 days later. So you can quantify the improvement of an asymmetry. Now, if we go with the arms, something similar, but this is also, I think, a wise way to quantify the neurological impairment. You can see the same patient, I believe it is, before and after 3 days, and the differences in the drift. So here what the algorithm does, here there's no drift, the movements are sharper, faster. So here, it shows you in this graph the maximum height, the velocity of movement, and the drifting between both arms. So, ideally, the two triangles should have basically the same shape, and the degrees of symmetry, or the mismatch between the both triangles is the mismatch is what we call the asymmetry, and you can also quantify how over time this asymmetry improves or worsens. And what else? This is not working. So how can we use this technology? Of course, we can use it when EMS gets on the field. We can use it when a patient comes to an ER, probably at primary stroke centers or centers with no specialized stroke team. You can triage them with these tools, but you can even do some kind of neuro exam even before EMS is there. In an eventual scenario, you can send a link to the witness that is with the patient, and very easily it just takes a quick video of the patient, and you can already, before EMS is on scene, have some kind of quantification or assessment of the patient. Obviously, you can also use it to monitor patients in the stroke unit. How many times overnight a patient deteriorates and nobody notices until next day. So if somehow we can place this technology in the stroke units and monitor our patients, we could identify worsenings maybe. And in the post-discharge and follow-up of the patients, we can also quantify improvements much better than with what we're using right now, which is the MRS or other scales. This is much cleaner and objective way to quantify over time neurological impairments. So I think I'm finishing here. We far beyond that what was thought. This is before even television was invented. They also thought that it could be used to do telemedicine. And again, we got there, and we are beyond what was imagined almost 100 years ago. Thank you very much for your attention.
Thank you very much, Mark. And as said, we will do the questions at the end, so keep your questions in mind, please. So we move now to the next phase in the hospital and even in the angio suite. What can we improve there? How can we speed up things in the angio suite? And Nicole Cancelliere is from here, from Toronto. She is a technician, lab technician, and she's well involved in all kind of research in that. And she's presenting here about the research she does in this in angio suite assessment of patients.
Thank you. Thank you all for being here today, and thank you to Philips for the invitation. As Wim said, I'm going to talk to you about what we can do once the patient arrives to the angio suite. So thank you, Mark, for talking about the great way in which we can save time in triaging patients with AI. This is some of the work that we did with Philips, looking at how we can get our patients to the angio suite faster. So over the past decade or so, we've had a lot of big clinical trials that have taught us a lot and have evolved the way we are using imaging to select patients for stroke. And so, more recently with the large core trials and extended time windows, we see that originally our focus or emphasis was on not only ruling out a hemorrhage and detecting the clot, but excluding large cores and tissues at risk. I think the role, you can agree, is changing, where we are more focused on detecting the clot and ruling out the hemorrhage, and perhaps now are more inclusive with the patients that we enroll in these later time windows and large cores. So if we look at the data from Hermes, from meta-analysis of the original Big 5 trials, we can see that we can save anywhere from 20 up to an hour of time if we can bypass CT or imaging to select patients and bring patients directly to the angio. So can we do this? Will we still get the information that we need from the angio suite technology? And this is what I will talk about in this talk. So we are able to acquire images called cone beam CTs in the angio suite. So these are CT-like images that are acquired over a 200-degree rotation, and a digital volume from a volumetric data set is reconstructed. And so we use this technology every day in the neuroangio suite for things like vaso-CT, where we are looking at, for example, stents, which you can see here. But can we use this for brain parenchymal imaging to assess for stroke? This is a picture of the first generation of cone beam CT, and probably you can agree with me looking at this image that it is not ideal for stroke selection, as we have poor gray-white matter differentiation, a lot of artifacts. So most people would not feel comfortable relying on this to, for example, rule out a hemorrhage or see an ischemic lesion. And why was that imaging so susceptible to these image artifacts? It's just in the nature of how those images are acquired. So you can see on the left here, cone beam CT, as the name implies, is a cone beam and has a flat panel detector. So this is susceptible to a lot of scatter. If we look on the right, compared to traditional conventional CT, we see we have a fan beam with a detector row for helical scanning. So just the inherent nature of it makes us susceptible to these artifacts. Also, if you are thinking about stroke patients, we have a lot of motion, agitation, particularly for our patients with large vessel occlusion that are confused. Our scan time for cone beam CT, because of the gantry and the hardware being different, is susceptible to a longer acquisition time. So when you have motion during stroke, we're going to see a lot more of those artifacts. And that all affects the image quality that we see. But this is an example of the images that we can acquire today with the Helical Smart CT, so after all of the developments that we had done over the past 5 years. So I think we will talk about this journey and how we got there and how we were able to acquire this. So there were 5 key things that changed over those 5 years. Detector technologies, the speed of the acquisition, we were able to shorten the bone beam hardening and different algorithms, including motion correction as well as actually changing the trajectory of the scan. So I'll walk through kind of our process and our validation and studies that we published looking at that. So over 300 images were acquired from 273 patients. You can see the statistics there. So the majority of patients being over the age of 65 with left MCA occlusion being the main largest group of patients. In the first study, which we published in EJR in 2021, we looked at how the older scans compared to the newer scans with the reconstructions. Then we looked at how the butterfly scan or an adapted trajectory could improve image quality and artifacts. And then the last was a post-processing motion artifact correction algorithm. These were all published in high-impact journals over the past couple years. So diving into the first study, the new detector technology that Philips developed had a better image contrast with a larger dynamic range, 14-bit detector, as well as higher image resolution due to smaller pixels. Additionally, we were able to shorten the time of the acquisition from 20 seconds down to 10 seconds and double the frame rate. So the dose was maintained, but we were able to half the amount of time. So that was the original propeller, just showing you that 10-second scan. And then there were post-processing algorithms that were able to correct the image. So this is just an example of a 78-year-old patient with a left proximal M2 occlusion. We can see here the left insular and lateral basal ganglia artifact, infarct here. But we can see there's a lot of image artifacts like bone beam hardening around the edge is hard to assess the parenchyma. The gray-white matter differentiation is not ideal, and particularly in the lower slices, we have some artifacts as well. This is a picture of that second generation, so that faster scan with those post-processing algorithms. We see that the bone beam hardening algorithms were able to clean that up, and we have a bit better resolution of the gray-white matter differentiation, improving our ability to assess the aspects. And here's just an example of the multi-detector CT. So we're moving in the right direction, but still at this stage have some improvements to make. So we looked at this qualitatively and quantitatively, and we were able to show that qualitatively, so this was scoring those images based on these 6 different factors, so noise, artifacts, gray-white matter differentiation. These overall, there was an image improvement in 42%, but the largest improvement was in the noise, the artifacts, and the gray-white matter differentiation with 50% or more improvement. We also looked at this quantitatively by drawing regions of interest and looking at contrast to noise ratio and mean image noise, and those were also significantly improved with the new scan. Looking at the butterfly scan, this is just an example of the caudal cranial angulation that is added to the rotation. So you can see it's a 15-degree caudal to cranial shift, still using that faster speed between 8 or 10 seconds. And so our protocol for this part of the study was patients who would arrive to the angio suite would have both the previous scan that I talked about in the previous paper and the modified trajectory scan. And then each brain scan was divided into 6 regions and scored from none to mild, moderate, or severe image artifacts. Here's just examples of some of the artifacts that this imaging is susceptible to. So we see beam hardening, these streaks, dark and white streaks. Undersampling kind of looks like these ray aliasing lines across the image. We have inhomogeneity, where one side of the image can be darker compared to the other. This can be due to head centering. Cone beam effects, which are due to the fact that we are using a cone beam where the tops or bottoms of the images are a bit darker. Patient motion, which looks like this streaking here along the edge of the image, and then also metal artifacts, which can be streaking across the image due to, for example, dental hardware, which we see here. So if we look at the comparison between the circular scans, which are highlighted in blue, and the butterfly scans, which are in gray, we see that there is a overall improvement in the image artifacts from butterfly to circular, but a most significant improvement in the beam hardening and the cone beam effects. So if we look at that, a patient example, this is an 87-year-old male with a left M1 occlusion. We can see that here on the left, the circular scan, we have these like dark streaks from the beam hardening and the cone beam effects. And then on the right, we see this dual axis butterfly scan where that is completely cleared up. So you can imagine that if we're assessing something in the posterior fossa or in the upper supratentorial region, this would be important, particularly for doing an aspect score. Here's an example of a patient with core enhancement in the cerebellar vermis, and we can see that they're streaking along here. We see this, contrast enhancement. We can much more clearly delineate and see that with our dual axis scan. So lastly, we investigated the motion artifact correction algorithm that Philips developed. Here we can see the process of how this works. So this algorithm is able to reconstruct arbitrary trajectories by doing a rigid 2D, 3D registration. So in real life, the stroke patient's head moves and the scan is stable, but what this algorithm does is simulating as if the head was static and that the scan was moving, and iteratively reconstructs this to create a new reconstruction. And so what we did for the validation study was to score all images that we acquired based from a 0 to 3 based on how well we were able to assess either a hemorrhage or a ischemic lesion. For example, mild being we could still assess hemorrhage or stroke, but there was minor movement or artifacts, whereas severe is inability to diagnose either of those. Moderate would be we could detect a hemorrhage, but maybe not an ischemic lesion. So looking at 310 of those scans, we saw motion in 51% of those scans, and 91% of those were able to be improved with this algorithm. So what does that look like for imaging? Here's 2 examples on the top and bottom of 2 severe scans, unable to diagnose a bleed or an ischemic lesion. And just with the post-processing algorithm, we were able to clean those images and score them at a 0 and detect, the lesion and an aspect score. So overall, with all of these improvements that have been done, we're able to achieve now a 93% effectiveness to use this imaging for stroke selection. So we even saw that the aspect scoring when we compared to conventional CT was improved and more accurate, not statistically different, whereas in the other data set, it may have been more hard to make that delineation. So we have talked about being able to rule out the hemorrhage. Can we detect the clot using cone beam CT in the angio suite? This is just a protocol where we are able to intravenously inject contrast while doing a dual phase wiper scan. So there's an early phase scan followed by a late phase scan 8 seconds later. And here's an example of what the cone beam CT looks like for a 56-year-old male with a right M1 clot. So we can see right there the clot. And if we compare that to the DSA, we can see that it is in the same location. We can also which is interesting, use that imaging to create a 3D and do a 3D roadmap to help us during the procedure. So for example, when you cross the clot and your wire is in the M2 branch, you can confirm that just from the overlay, not needing to do a microcatheter injection. And we can also assess collaterals just based on the 2 time points, which we validated by looking at the DSA. So overall, the recent advancements in AngioSuite cone beam technology is able to improve image quality assessment for stroke, supporting a direct-to-angio approach. This has the potential to save time and brain, which is being investigated now with the We Trust trial cone beam CT triage. So with that, I'd like to thank you all, and if you have any questions, you can ask, I guess, at the end of the session. Thank you.
Thank you very much, Nicole. So now it's my turn. Yes, so wake up. It's not wake up after your delicious lunch, but I want to pronounce a call here to select a group of patients and to treat them differently than we do currently. And this is not in my interest, it's really in the interest of the patients, this talk. So endovascular treatment, as you know, that since 2015, since we published those landmark trials, we treat those patients endovascularly when they have a large vessel occlusion and when they are in the hospital within 6 hours. And why is that? Well, you see this graph that is from the Mr. Clean trial, which had the broadest inclusion criteria. If you select all those patients and you treat them, then the treatment benefit disappears after a certain time. And here it was more than 6 hours, but a little more than 6 hours, then you don't have a significant treatment benefit anymore. And that's the reason that in the guidelines it states that within 6 hours you treat those patients, but not beyond 6 hours. That changed a few years later when several trials showed that also in the later window, after 6 hours, up to 24 hours, you can treat those patients when you select them. And the selection was like this. In the 2 trials that have been published at that time, the FUSE and the DAWN trial, there was a quite strict selection based on advanced imaging, CT, perfusion, or MRI. And if you selected those patients, then there is a treatment effect in the late window as well. Similar thing happened for intravenous treatment. As you know, in 1995 already with the NINST trial, it was shown that intravenous treatment was beneficial in a certain group of patients. Well, in fact, if you give it to all patients with a stroke and no contraindications, you can treat those patients, but within 4.5 hours with the same rationale. You see in this publication that after 4.5 hours, the treatment benefit is not significant anymore. So the guidelines state that that after 4.5 hours, you can treat those patients if you select them based on either CT perfusion or diffusion-weighted imaging. This is still based only on the wake-up trial with diffusion-weighted imaging. But here is the European Stroke Organization guideline, and says that if you select patients based on CT or MRI in the late window, you can treat those patients. And that is based on these 2 trials, the wake-up and the extend. Wake-up using this flare DWI mismatch. I'll come to that later. And the extend trial based on CT perfusion. So again, if you select patients based on advanced imaging, after 4.5 hours, you can treat them with IV treatment. But it also states that if you do not do advanced imaging, then it's recommended not to give intravenous thrombolysis. So why do we treat patients without advanced imaging in the early hours, IV treatment and endovascular treatment, and we need advanced imaging in the late window after these hours? I want to show that with a graph coming from this paper. This is the same research group as did the wake-up trial, and they tested here their flare DWI mismatch algorithm with a group of patients with a known onset time. And they said, look, we have a known onset time, we have these onset times more or less, and we see already here that in the early hours there are patients with flare lesions. In fact, it's similar like the other algorithms. You have a large core or no mismatch. Those are in fact the patients that will not or have a low likelihood of benefiting from the treatment. The other group here, that is the group that you will treat because they will have a benefit. And it's all based, of course, on the idea that some patients progress fast towards a large core where you can't save anything, the fast progressors, and you have the slow progressors where the collaterals are still good, and you can treat them in a later phase. This is a nice publication from a Korean group that shows exactly if you have good collaterals, then you have more time. You can treat more patients in the later window. But those fast progressors, those are the ones you have to treat very fast. As soon as they are in the hospital, please don't lose any time because they deteriorate within minutes. And that's what I wanted to show you here. So we have patients that benefit from the treatment and patients, this is very black and white. Of course, there's some nuances in it, but you have patients that do not benefit. Also, in the early hours, there are patients that probably do not benefit, the fast progressors. But we don't care, we treat them all. Only in the late window, you have so many patients that probably don't benefit that you need to do some selection, else you will treat many, many patients without a true benefit. And the same for endovascular treatment. You have a bit more time. You can treat a bit later, up to 6 hours. But again, also within those 6 hours, there are patients that will not benefit, but we don't care about that. And in the late window, you should not treat all those patients because then you treat too many patients without a real benefit. Why do we neglect, in fact, this advanced imaging in the early window? Why don't we spend time on selecting in the early window? Because, as I said, there are patients that probably don't benefit well. Time is brain, you all know that. And here, this is a nice publication that shows that every 1 second in general of delay, you will lose some hours of healthy life. So every second counts, and especially in the early hours. And you lose time in the early hours. This is an analysis from the Swift Prime study that shows that if you use CT perfusion imaging, you lose some time. You lose even 24 minutes if you look at CT perfusion, even in the early window. So you lose time by using advanced imaging. Another problem is that the advanced imaging is not that reliable in the early windows. These are a few publications, and the group of Mark published about that and called it the ghost infarct. In the very early window, there are infarct sizes that seem to be much bigger than they are, in fact, in reality. So they advise that patients should not be excluded from reperfusion therapies based on this advanced imaging, especially in the early hours. So if you treat patients or you select patients in the early hours, probably you will filter out a few patients that would benefit, in fact. So there is a good reason that we treat patients without additional imaging. Time is crucial, and you lose time is if you do advanced imaging. And it's unreliable in the first hours. But in the late window, yes, there's a good reason to use advanced imaging, because if you treat them all, you will have a lot of patients that will not benefit from the treatment will be inefficient, and you have a little bit more time because the slow progressors are mainly in that window. Now, what about wake-up stroke patients? That is the majority of those patients in the what we call late window. It's even up to a quarter of the total number of patients that arrive in the hospital with a stroke. And if they are early window, you should treat them as fast as possible. Don't lose any time on advanced imaging or whatever discussion. But if they are late window, as I said, there's a good reason to select them based on advanced imaging. Now, we select them based on their last known well time, and that's mostly the evening before. And automatically, they become part of this late window group. And we do the advanced imaging, and we lose time, and we deselect some patients probably. Is that correct? Should we use this last known well time as a proxy for the onset time of the stroke? Well, I used this same publication from the Wake Up group. And what they had shown, and you saw that already in that graph, that in the early window there are some patients with flare lesions. In fact, the sensitivity was 62%. That means that already 38%, 1/3 of the patients in the early window have already flare lesions. So in their trial, they were not selected, they were not in the trial. So within 4.5 hours, 1/3 of patients had already flare lesions. Now look at their trial, the Wake Up trial that came later. They treated only patients that came in the hospital within 4.5 hours after waking up. And what did we see? If you look at the supplemental material, so all screened patients, 1/3 of the patients arriving within 4.5 hours after waking up had already flare lesions. That's exactly the same cohort of patients as the ones that we know have their infarct within 4.5 hours. For me, well, it's kind of secondary evidence, but this group is the same. And now, later, the same group published this nice study where they used a relative signal intensity flare algorithm to estimate the time that the stroke happened before the imaging. And look at this. The last known well time, the distribution of the last known well time of those patients is in the green line. So that's a long period before. You know, it was when they went to bed. Some people go to bed early, there's a longer time. When they go to bed late, they have a shorter interval, but still it's more than 4.5 or more than 6 hours, usually. The time that they have their imaging from waking up, that is this line. So the blue line is the time they woke up with stroke. And the red line is the time that they estimate they had their stroke. That is nearly the same time as when they woke up. And if you see it in this table, 90% of the patients had their stroke within 1 hour from waking up. So they all had their, more or less all had their stroke just before waking up. So their conclusion is that the minority of those, the majority of those patients with a wake-up stroke have their stroke just before waking up. And that idea has been tested in a few trials already, where they just selected patients within 4.5 hours based on non-contrast CT. So they didn't use any advanced imaging. They just said, okay, we do a CT. If there's not a large infarct, no hemorrhage, etc., they can have IV treatment. The SAIL one was the first one. They said, well, you could do it. It's feasible. It's safe. And the TRUST CT is another one, already published in 2020 again. They did the same within 4.5 hours after waking up. Just treat all those patients. Don't look at any advanced imaging. And they have the same idea that you should, or you can at least, treat all those patients within 4.5 hours after waking up. So for me, I think the thing you have to remember is that, of course, not all patients in the early window benefit. You have those fast progressors, but we don't care. We treat them all. You don't want to lose any time for the large majority that needs the fast treatment. And in the late window, there are a few patients that will benefit, in fact. And you have to select them. Those are the slow progressors. You have to select them with any algorithm. We did with the Mr. Clean late trial. We looked at collaterals, if there were collaterals present, but it's the same idea. You have to do some selections, else you will have an inefficient treatment. So if you treat them all, it will be inefficient. So you can lose a little time with this advanced imaging. But wake-up patients, I think we should consider them as early window. We should not lose time. A lot of fast progressors are still in this cohort of patients. And therefore, I would say, forget about last known well. Don't even ask for it, because it has no use in selecting patients. When they wake up, just start counting from the time they wake up. And if it's within 4.5 hours, just give IV treatment. If it's within 6 hours and they have a large vessel occlusion, just go to the angio suite and forget about this advanced imaging for this cohort of patients. And as I said, it's more than 20% of the stroke patients currently in our hospital. So I think we do a lot of injustice to those patients with the current guidelines. But to change the guidelines is quite difficult. I think we need real evidence. And all I showed you is secondary evidence. But I hope I can convince you at least. So thank you. And then we move on to the next speaker, which is Manish Wadhwa from San Diego, worked for Philips as a technician, and he will talk about the last phase that we have in those stroke patients, the follow-up monitoring of patients after a stroke.
Thank you, Tim. And let's see. All right, good afternoon. So my name is Manish Wadhwa. I'm a cardiac electrophysiologist, so changing gears on the neurology community here. And I'm actually here more in my role as the Chief Medical Officer for Philips Ambulatory Monitoring and Diagnostics, which is one of the 4 divisions of Philips. My disclosures, full-time employee, and also chairman of the board of a startup company. All right, so we're going to start by talking about monitoring, because it always amazes me how when I'm talking about monitoring, that translation doesn't necessarily happen at the either neurology or even primary care level. So let's talk about Holter, extended Holter, MCOT, and ILR. So what is a Holter? A Holter is the old form, fashion of monitoring that we're aware of. So multiple wires. Obviously, the picture there is meant to be unsettling because it is a very cumbersome process, very limited on what we can get, 24 to 48 hours of data. Nice thing is you can get multiple leads or multiple views into what's happening within the heart. So now the newer technology is extended wear Holter. So we have an e-patch, for example, with Philips. And here it's a set it and forget it, stick it on, however you want to say it. You can wear the monitor for up to 14 days. Very simple, gives you 1 to 2 leads of electrocardiographic information. Beyond that, in the US, we have what's called mobile cardiac outpatient telemetry, which goes not just to 15 days, but extends out to 30 days, and also simple, set it and forget it. And now we give you a cell phone that goes with your patch, and that data gets translated to us in near real time to a monitoring center. And if we identify arrhythmias, we're contacting the patient and or customer, depending upon the arrhythmia identified. And then lastly, there's the move to the implantable loop recorder. And as we know, the beauty of these is you have 3 to 5 years of data, but let's also remember they're invasive and extremely costly and burdensome. Costly not only for the implant, but for monitoring. The way I actually ended up at Philips is I actually started a company called Geneva back in 11, sold that company to Biotelemetry in 19, and our revenues were all really driven off monitoring implantable loop recorder devices. So I've been around the block a few times on how much work it is to monitor that data. And of course, the one limitation of the ILR, it's a single lead. And I say lead because it all depends on how I insert that into the chest, whether that's AVF or 1 or 2, and it moves. So it could be lead 1 at one point, and later on in life, it's an AVF. So we'll take lead with a grain of salt in the ILR world. All right, so let's, when we talk about the diagnostic yield of atrial fibrillation in cryptogenic stroke or TIA, we know that the longer we monitor, the better. So going back to 2014, Gladstone even demonstrated going from 24 hours, so think Holter, to 14 days, think extended wear Holter, to 4 week, think mobile cardiac telemetry, your yield of atrial fibrillation will go up. And of course, that information is only compounded by Crystal AF, which everyone knows about, cardiology, neurology, internal medicine. And in Crystal AF, what they found is going over 3 years, when you compare to a standard arm, which used Holter, right? I mean, comparing 24 hours of monitoring to monitoring 24/7 going over the long term, of course, you're going to find a much greater incidence of atrial fibrillation identified on the implantable devices. So the first lesson we will accept and learn is the more you monitor, the more you find. So now let's think about beyond just duration. Let's think about how we monitor. So when we look at the detection over the first month of monitoring, whether you're using an implantable loop recorder or using MCOT data, you'll see a difference. And that's because the devil is in the details. This is one of my favorite sayings. When you slap a monitor on, there's different algorithms at play, there's different definitions in play, so you are going to get different results based on the monitor that you use. So if you look at this data from Sposato, in the first 21 days, you get about 4% AF yield on an implantable loop recorder. But when you look at those patients on MCOT, we're demonstrating 20% here. On another meta-analysis, you can see 13 to 23%. And if you translate that out into the Crystal AF world, well, in the Crystal AF world, at 1 month, they found 4.5%, and at 1 year, 12%, 22 months, 20%, and 24 months, 23%. So I always ask people, why, if you walked into the mechanic and the mechanic said to you, hey, I can figure out what's wrong with your car. I can either figure out quickly or I can take a long time. Well, you're going to say, well, I'd like to know quickly. And then he's going to say, well, it's actually a lot cheaper to do it quickly. It's more expensive if I take a long time. You're going to look at him and say, are you an idiot? I want to find out quickly, and I want to do it cheaper. So how you monitor actually matters. So how you monitor impacts time to AF identification. Next, anticoagulation initiation and control and intensive monitoring groups. So when you look at all the studies that have compared a standard monitoring group, a standard Holter group, to more intensive monitoring. In Boreani, they used an implantable loop recorder from St. Jude. In Find AF, they used 3 10-day monitors versus a conventional Holter monitoring system. In Mondafus, they used 7 days of inpatient telemetry monitoring. In Per Diem, it was a 30-day monitor versus an implantable loop recorder. And in Stroke AF, it was an implantable loop recorder in the intensive group once again. And what you look and see is, well, hey, when you monitor more, of course, you find more AFib. We already established that. But what we also find out is that when you monitor more and you identify more fib, we actually do a really good job of anticoagulating those patients. And that's what's demonstrated here in the red. When you find atrial fibrillation, we do initiate anticoagulation quite effectively. So lesson number 3, when AF is identified, anticoagulation is effectively prescribed. Next, now let's look at the punchline. Recurrent stroke in the control and intensive monitoring group. So let's take the same studies and let's look at the recurrent rate of ischemic stroke in these patients. Now remember, these patients had AFib identified, these patients had anticoagulation initiated, so we should be preventing recurrent strokes. Well, the green bar in the intensive group, in the Boreani paper, we actually saw a trend toward increased strokes in the intensive monitoring group. All other studies showed a trend toward decreased strokes. However, every one of the p-values was insignificant. So, at this point, anticoagulation of AFib post-stroke does not equal prevention of recurrent stroke. So, a lot of data, a lot of work has been done in this space. Again, referencing Sposato. I told Luciano he's got to pay me for all the referencing I'm doing over here. And then, so his work going back to 15, and he actually really eloquently demonstrated how you can sequentially find atrial fibrillation in ischemic stroke patients, up to 24%. And he's actually also pushed this concept of AFDAS, which is one of my favorite terms because in the US we have AFLAC. And if you don't know what AFLAC is, I keep telling him I got to send you this duck. It's a classic commercial, but I keep turning it into AFDAS. But AFDAS, atrial fibrillation diagnosed after stroke. So the concept that's being promoted is that let's look at an embolic threshold. When somebody has a stroke and they have known atrial fibrillation, well, in order to have that stroke, they actually exceeded some level of an embolic threshold, right? And we don't know what that threshold is. We think it may be related to atrial cardiomyopathy, cardiac comorbidities, atrial fibrillation burden. The data suggests that, but there's still a lot of open questions. Well, the concept of AFDAS is there might be AFDAS patients that are higher risk for stroke. In other words, they too will exceed this embolic threshold and be at risk to have a stroke. But that's different from other patients who may not exceed that, that embolic threshold and suffer a stroke. Now, taking that concept further, recent data has actually shown that if you identify atrial fibrillation on an ECG versus on a 14-day monitor, you have a higher recurrence rate of stroke when you identify on an ECG. This brings into a concept, a different thought, that the more you monitor, what you see may not be as significant. In other words, if I'm looking at that outside here and I'm looking to see what happens to that door and I have a camera on that door 24/7, that's very different than if I catch somebody walking in that door on an isolated snapshot. How you look, it's the difference between a picture and video actually has impact on what happens to that patient down line. So let's take a lesson from cardiac electrophysiology, right? So I was at a symposium last night, and frankly, I will laud the neurology community for all the work you're doing on thrombolytics, on intervention, and it sounds a whole heck of a lot like what happened in cardiology over my career, right? I've been practicing EP for 23 years. I know you're thinking, you look so young. No, I'm not. But that being said, let's take some lessons from cardiac electrophysiology. So, having practiced now for 23 years as an electrophysiologist, what do I deal with? I deal with, take a guess, atrial fibrillation. We deal with implanted patients with pacemakers, defibrillators, and I told you I have all kinds of experience on those implantable loop recorders. So we've been seeing patients over all these years who have what looks like atrial fibrillation identified on these implantable devices. And we've been stuck with the question, what do I do with these patients? Should I anticoagulate? Should I not anticoagulate? Is it aspirin or is it an anticoagulant? So this is an excerpt from the European Heart Journal. So the terminology that's now being used is atrial high rate event and subclinical AF. So let me walk through this real quickly. So if you have no symptoms attributable to AF and you've not been previously diagnosed with clinical AF, and clinical AF is diagnosed when you have an ECG or a telemetry recording which shows greater than 30 seconds of atrial fibrillation, or you have a 12-second EKG showing atrial fibrillation. Those are the two ways. 12 seconds on an EKG, 10 seconds on an EKG, or 30 seconds on an external monitor. And so when we look at these patients, I'll get a tracing on their device, and what I'm showing here is the atrial lead, and that atrial lead shows rapid atrial activity. That tells me that patient has something going on in the atrium. And whether that comes from a pacemaker or a defibrillator or from an ICM, which is an intracardiac monitor, which is an ILR, we then look and say, hey, does this patient have an ECG? And if there's no AF on an ECG, we term them subclinical atrial fibrillation. When we identify this on an implanted device, it's called an atrial high rate event. And without an ECG confirmation, it's called subclinical atrial fibrillation. And then, if I do, however, have an ECG demonstrating one of those two findings, which I was talking about before, now that patient has clinical atrial fibrillation, right? And one of the most important trials in this regard just came out, and that's NOAA AFNAT6. It was just presented last month in Amsterdam at the European Society of Cardiology. So what they did in NOAA AFNAT6 is they took patients who had subclinical atrial fibrillation, who had it for over 6 minutes in duration, and the average age was 78, average CHA2DS2-VASc score was 4, average duration of fibrillation was 4 hours, and they anticoagulated that group, just like we've all been doing as cardiologists for all these years. And what did they find? When you randomized that group to either anticoagulation or placebo, there was no impact on recurrent stroke, systemic embolism, or death with anticoagulation. Further, what they did find was there was a significant increase in bleeding from the use of the anticoagulant. So this has turned the cardiology world upside down. So that means we're not there yet because this is NOAA AFNAT6. Artesia, which is a very similarly designed study, is going to either be presented next month at AHA or at the beginning of next year. So we will see if that reaffirms this study. But I will tell you, Artesia was also stopped early, just like NOAA AFNAT6 was. So we're figuring we're going to get very similar results. So many questions. I think I'm out of time, so I'm not going to be able to go through all the questions. But we have to figure out what is atrial fibrillation. Is it really the rhythm, or is it the atrial myopathy? As you all know, Arcadia was released at ESOC this year, so that's a question that's open. We need to figure out what the right duration of fibrillation is. It amazes me, this concept of 30 seconds, and so many in this room, if I took a poll, would treat somebody who had atrial fibrillation less than 30 seconds if they had a stroke, and then others will tell me they won't unless it's over 30 seconds, and others will tell me it has to be 6 minutes, or from the cardiology literature, 24 hours from a CERT has really shown benefit. So we really need to figure out burden density as well. We need to figure out whether known AFib and AFDAS are the same disease, or really are subclinical AF a cardiology term and AFDAS the same disease, and are they different from known atrial fibrillation? I'm really beginning to wonder whether that may be the case. And of course, we need to figure out the value of near versus long-term monitoring and what we identify. And this is a very important aspect. How sophisticated are our advanced systems, right? In Europe, it takes you 6 to 9 months to get a monitor after a stroke. 6 to 9 months. You think we're better in the United States? It's more like 2 months. I mean, this is, you just had a stroke and you got to wait 2 months for a monitor? Does this make sense? And lastly, can we combine telemetry monitoring with factors that would make it more attractive, like biomarkers? So that's it. I'll stop there. Thank you very much. Sorry for going over.
Very interesting, and I learned a lot again about atrial fibrillation. But we have a few minutes left, so are there any questions? Did you remember some of your questions from the earlier talks? I remembered one for Mark, I think. Do you know how accurate is this tool at the moment? And I was a bit triggered that you said you can even use it at home by relatives that find a patient, because I think that the more in the early phase you are, the less, well, I would guess, specificity you have, because you have many more other potential problems. Could this recognize it from this large group of patients with insults, with cardiac problems, etc., etc.?
No, we are currently learning how is going to be the use of the case of use. We just launched the trial that supposed to lead to FDA approval in our set of patients that the prediction is very high. Is over 80% in specificity and sensitivity.
But that was in the hospital.
That was for patients in the hospital. So again, for this kind of trial, it's going to be difficult to do the validation at this point in ambulances. But that's the plan, and I just only showed some examples how potentially you could use it. But I think the first step is to use it in primary stroke centers or at the emergency departments, and progressively expand it to the ambulances, and there from there eventually, as I showed, to other scenarios.
Yeah. We don't know yet how accurate it is in these settings. Still no. Yes, there's one question.
Thank you for all those wonderful talks. My question is on diffusion flare mismatch. Suppose a patient has diffusion changes in the whole of MCA territory compared to a patient maybe 1/3. So is there any differentiation between the one who has whole of MCA diffusion flare mismatch versus, would you still go ahead with that patient?
Well, we never use, by the way, MRI. But if you have already DWI lesions in the whole area, it depends a bit on if it is scattered or if it's a whole infarcted brain. That makes a difference. Yes, of course, we look at that. But that's not affect my message. My message is that if you have a patient with a wake-up stroke, then consider it as a patient that has its stroke from the time they wake up, and then you do the same as you always do with your imaging. If you still use imaging in the early phase, well, you can. I would say you shouldn't, but if you do it in your hospital, you can. But it's more the concept that you consider them as early window patients, and then you can do whatever you do with your imaging tools or with your selection algorithm.
Thank you.
Any others? So before there's one more.
In a way, I'm rather sorry to ask these questions. I was particularly fascinated by the development of the cone beam CT, but two things came up. One is, why did you do it? And the other one is, if you are scanning people and you have to scan them twice, isn't that a lot of X-rays? How ethical is that? And does it create a delay? And presumably you chose patients which delay didn't matter. Sorry to ask these kind of fundamental questions.
No, it's okay.
But fascinating though it was, I was left with those questions.
No, those are great points. So the scans themselves only take 10 seconds. So if you're doing the scan, it's relatively minor cost for the huge value of the information that we got from it, right? So in order to be able to say, let's bring patients directly to angio, there has to be a validation that we can rely on this imaging. So from this work, we could say we can detect an ischemic lesion or a hemorrhage in 93% of our patients that came. So that I think was really valuable information. And yeah, it was all for this direct to angio. Why did we do it in the first place? Not only can we use this technology for stroke, but some of the validation work, for example, was done on a ruptured aneurysm. So they're already intubated, they're in the procedure, we're doing the cone beam CT. So we were able to do validation also in other procedures just to see, for example, blood and things like that. So.
Yeah, 10 seconds is good.
Yeah.
So just to add here, if you just skip what is the conventional imaging and you do all your selection with this new technology, you can go down to door to groin puncture of 10 minutes, which is and you cannot imagine you can get there if you transfer in the hospital the patient from multiple sites to the. This is the ultimate value of this quality of image.
Yeah, I think that's exactly the case what you're doing with your retrust study as well, that you show that if you bring patients fast to your angio suite, of course you will have, you expect to have a better outcome for those patients, but you need a very good tool on your angio suite, and that's what you are looking for. How can we improve it? I think that will be a future. So probably we can skip a lot of CT imaging, whether it's CT perfusion and CT angio or even CT, and go directly to the angio suite. But that's all work in progress, I think, and Philips is helping us a lot to achieve this in the future. But we're running out of time, so I have to conclude this session, and I thank you all for this fantastic talks. And if you have questions afterwards, we are walking around, so you can ask us all the questions you want, and we will be happy to answer them. Thank you very much for your attention here, and see you around.